With that, we'll move on to our third case. This is a 64-year-old woman who also presented with blood in the urine, hematuria, treated for UTI for a bit, but didn't get any better. Ultimately, a CT scan, which showed a 2-centimeter bladder mass, a little bit smaller than an inch. No evidence of any extension beyond the bladder. No enlarged lymph nodes. The kidney was not blocked off as it was in the last case. The urologist was able to completely resect all of the 2-centimeter tumor. Pathology came back as invading into the muscle wall, so a T2 urothelial cell carcinoma. There was no carcinoma in site 2 present from other spots of the bladder. Otherwise, a healthy woman, and has, I think importantly, no bothersome urinary symptoms whatsoever. So here is a person with a relatively small solitary mass that's been resected and comes to us. What are the different treatment options? Dr. Liao?
Yeah, so this is a patient that's fortunately healthy enough for a variety of options, and obviously a very standard option would be surgical management with a radical cystectomy, like we talked about with the last case. As Dr. Grievous went through, there's an improvement in outcomes with adding chemotherapy up front before cystectomy. But this is a patient actually that raises the question whether there's a role for trying to preserve the bladder with chemoradiation. So I'll go through a little bit of kind of the background for that. So can the bladder be preserved safely, and can we also treat the cancer effectively at the same time? So this is a strategy that's been looked at across many types of cancers of trying to preserve organs, basically. So it's used in head and neck cancer, it's been used in anal cancer. In bladder cancer, this is pioneered by a group at the Harvard Hospital, Massachusetts General Hospital, as well as groups in Europe from Paris and Germany. And what they found is they basically stumbled on it like many medical discoveries, and they were looking at patients that were actually undergoing surgery, but before surgery they had chemo and radiation. And they were surprised that there were a number of patients that actually had a complete response by the time the bladder was removed. So this led to investigation of, well, maybe we could actually use chemo and radiation as the primary treatment in lieu of surgery. So this led to work both by European groups as well as from cooperative groups in the US and Harvard group looking at this in a careful fashion. Overall, this has been less widely used in the United States compared to internationally, where it's done much more often, but in specialized centers in the US and tertiary care centers with a little bit larger volume of patients with bladder cancer and with groups that have expertise in this approach, it's something that has been used and can be successful. This is the overall lay of the land, just briefly, with how we approach bladder preservation. So the role of the surgeon is still important here, and that's successful outcomes with bladder preservation are tied to actually being able to clear out the tumor to begin with as maximally as possible. So doing a maximal scraping or TURBT procedure. Following that, patients undergo concurrent or at the same time chemo radiation. So radiation is a daily process over weeks of therapy, generally over about 7 weeks, but it's a split course where about 2/3 of the way through the treatment, we do a repeat assessment. So patients go through about 5 weeks of radiation and chemotherapy, often given weekly. And then at that point, we take a break, and for about 2 or 3 weeks or so, there's a reassessment of where we do repeat cystoscopy to see if there's a favorable response. So if there's no residual tumor at that point, we typically take a biopsy, then patients go on to complete what we call consolidative or some additional chemotherapy and radiation for about 2 weeks, 2.5 weeks. If there's persistent cancer, then our impression is that this is probably not the best strategy to continue with, so the patient would be best served with a cystectomy at that point. So that gives us a little bit of an early look into whether the treatment's effective. Importantly, after we get done with the treatment, if a patient does go through chemoradiation, it's important to have very careful cystoscopy surveillance because we want to catch if there's any persistent or any recurrent cancer to still give us outcome for dealing with recurrence at an early point. In brief, these are about the outcomes that we've seen with bladder preservation across numerous studies. The overall response rate at the end of treatment is in the range of about 75 to 80% as far as a pathologic response with the treatment. This does mean that there's about a 20 to 25% chance that there could be residual tumor after the treatment, which would be an indication for doing a cystectomy. And some patients may have a complete response, but later on down the road develop something that comes back in the bladder. So this is a testament to how important it is to continue with close surveillance and why the involvement of the urologist is still really key here, even though we're treating the patient with primary chemoradiation. Some recurrences are actually superficial recurrences where you may not have to remove the bladder, and some may be muscle invasive where we would have a discussion of whether to do a salvage cystectomy. The rates vary across different experiences, but somewhere around the order about 10 to 30%, there may be a chance of still needing the bladder removed in the long term. So it depends a little bit on how carefully you select the patients. In our experience, it's been on the lower end of that, and many contemporary series hover around 10 to 15% chance of needing bladder removed in the long term. So this does mean that a large proportion of patients, when carefully selective, have success with having an intact bladder. So in an ideal world, we'd have a head-to-head comparison. I don't know if there's any boxing fans out there, but we would have loved to see a head-to-head comparison of Floyd Mayweather and Manny Pacquiao. But randomized trials and head-to-head studies are difficult to complete, especially like this. So it's hard to say how these measure up. At least available data that's tried to look at this retrospectively suggests that the outcomes may be similar when you look at similar stage patients. And this was just one careful analysis by a European group that took about 100 matched patients, 50 that had chemoradiation, 50 that had surgical management with similar characteristics as far as the stage and appearance of the cancer, looking at the long-term survival outcomes. And as you can see from the lines there, they were pretty much overlying, suggesting that you may be able to achieve very similar results with this strategy. So one important key is that you have to select patients carefully for this approach. So the ideal candidate that is a patient that might have good success with having good response with treatment and saving their bladder is one that has a small tumor that's in only one location or unifocal, that's able to be cleared maximally by the urologist with a TURBT beforehand, no spread to any lymph nodes, and ideally just in a single location without any evidence of what's called carcinoma in situ or sort of precancerous change that would increase the risk of having recurrence in the bladder down the road. And importantly, in this case, which is in contrast to the prior case we discussed, no evidence of any kidney blockage or hydronephrosis is also an important factor. And we try to select patients that, with considering the rest of their health and their baseline function, have good bladder function to begin with, so that we're actually providing meaningful improvement in their quality of life in the long term. So it turns out only a subset of patients are really good candidates for bladder preservation. But this is a case where I think with a small tumor that's solitary, that's easy to be cleared with the TURBT and with no hydronephrosis, that this would be a patient that I would be discussing in BCMC what the merits and pros and cons are of chemoradiation.
Yeah, and this is one where certainly then we're presenting to the patient a choice where there are two good options for consideration. Now, one of the points that we have to have in the discussion is if they are in that 10 to 30% that need to have a cystectomy down the road, it can be a harder operation. We do know that there are radiation does cause some scarring, and so there can be more issues where we sew the ureters into the bowel. There can be issues where the bowels are sewn together. They're still very manageable, and we certainly do these operations. But it is important to have these discussions so the patient can weigh the different pros and cons. We typically will not offer a neobladder in these settings because of the prior radiation and the scarring effects from it. But certainly, great patient for us to consider offering them different options. And certainly having BCMC, as Dr. Liao said at the beginning, we have increased the number of patients who have been offered and selected bladder preservation with good outcomes. But I'll reinforce again his comment that we do this for the appropriately selected patients. Patient selection is key in this scenario. But again, even in this patient, there can be options for clinical trials as well.
So one exciting thing that we're involved in that actually attribute and recognize Dr. Wright's leadership enthusiasm in this is a study of trying to improve radiation targeting. So we're working with a company that manufactures this gel material that actually can be used as a marker, an imaging marker. So it's called TraceIt. So we have a small pilot study led by one of my colleagues, Dr. Zhang, that's looking at a temporary dissolvable marker to help to basically paint and localize where the tumor location is. So this is done at the time that the tumor is removed, or TURBT, during the time of the endoscopy. And basically we place these tiny gel markers along the borders of where the tumor was removed, and we can use this for radiation targeting. So we have an ongoing clinical trial that's open at the SCCA looking at this. Just a few images here to illustrate how this works. Basically, cystoscopically, like I said, while the tumor is removed, this initial picture towards the upper left shows before the removal of the tumor on a CT scan. So you can see the tumor along the left side of the bladder there. To the right of that image shows our radiation treatment planning scan after the tumor has been removed. And then markers were placed at the time of the TURBT procedure that now we can see really clearly, almost like a bullseye of actually where the tumor was removed. I don't know if you can appreciate there, but in the absence of those markers, it would actually be a little bit challenging to localize actually where that tumor is effectively. So that gives us greater confidence that we're hitting the target. And then now we have technology nowadays during the delivery of the radiation therapy to actually verify this in real time each day just before treatment. There's a low-dose scan called a cone beam CT scan that's built into the treatment unit that actually allows us to see those markers then and then align the radiation beam so that we can target the tumor very precisely.
Dr. Grievous.
I think that, this is an example of how we can have a team approach and present two options to the patient. And at the same time, through clinical trials, again, we can even move the field forwards, right? So Dr. Liao did an excellent job outlining how we would do radiation in that patient. And usually we try to use chemotherapy together with radiation for those patients who can tolerate chemotherapy. And chemotherapy in that particular context can be one of three different options. We can use either cisplatin alone or once every week, or another drug called gemcitabine alone once every 3 weeks, or a combination of 5-FU, a different chemotherapy drug, with mitomycin C. So there are three different chemotherapy recipes or regimen that we use in conjunction concurrently with radiation if someone can tolerate chemotherapy. Sometimes patients may not be able to tolerate chemotherapy whatsoever. Rare scenarios in that case may get radiation alone, but the preference is to get concurrent chemotherapy and radiation. How can we improve the field? How can we move the field forward? One idea would be to combine chemotherapy, radiation, and potentially immunotherapy. And this idea is being tested in clinical trials to see if the idea works. And that trial by Dr. Ballard in NYU is testing chemotherapy, radiation, and this anti-PD-1 checkpoint inhibitor together to see if this triplet effect can improve outcomes in patients with muscle-invasive bladder cancer. In a similar mode, we have a really large clinical trial that is being launched in multiple parts of the United States. We call this a SN SWOG NRG 1806 trial. A very important trial with multiple of us being involved across the parts of the country. We try to answer the following question: chemoradiation by itself or chemoradiation plus immunotherapy, whether again the trifecta is better than the doublet. And that's what we try to do by randomizing patients into either chemotherapy and radiation or that combination plus the anti-PD-L1 agent atezolizumab. This trial is looking at patients who have even hydronephrosis, which is allowed only if it's in only one side and the kidney function is good enough. So it allows a little bit more patients compared to what traditionally we have used chemoradiation at. And we're going to look at the percentage of patients who are alive without cancer and they still have the bladder in place. And we have a lot of other metrics or endpoints that we're going to learn from over time. So we highly encourage multiple cancer centers in the country to think about that trial as we go forward. And we're opening this trial, we're in the process to open it at the University of Washington and Seattle Cancer Care Alliance in the next few weeks. To conclude here, I think as an academic medical center, we keep mentioning the words clinical trials. And this last slide is just an overview of the management of bladder cancer that I made a few years ago. It's a 1,000 feet view, all the way from non-muscle invasive bladder cancer through muscle invasive bladder cancer, localized, organ confined, all the way to metastatic disease. And as you see, in black is what the standard therapy is, with intravesical therapies, neoadjuvant cisplatin-based chemotherapy, cystectomy and pelvic lymph node dissection or concurrent chemoradiation. In red, you have a plethora of different clinical trials that we have embedded in different pockets, spaces, and settings of this disease to try to include opportunities for patients and try to improve the outcomes of those patients and try to move the field forward. How can we use novel agents like immunotherapy in different combinations? And we do have multiple options available for patients, and we have a balanced discussion for the right patient at the right time. What is a standard of care therapy and what is a clinical trial option? And we have this through balanced discussion, patient can decide what is the best fit for him or her. Overall, I think it's a wonderful experience and patients really enjoy this multidisciplinary approach. So all very thankful here, Dr. Wright, Dr. Liao, and myself, to have the opportunity to present this multidisciplinary idea. This is how we function. That's how we do it every Tuesday morning at University of Washington Seattle Cancer Care Alliance. And we look forward to hearing any questions from the audience. Thank you so much for having us.
Thank you all so much. I think those patient cases were really an example of how this group discussion helps to really work together to explore the best options to recommend to the bladder cancer patients. So for the attendees on tonight's program, I think you got a glimpse a little bit about the behind the scenes discussion of how a multidisciplinary team works together. And as Dr. Grievous and everyone pointed out, a lot of times the best solution might be a clinical trial to explore many other options that may not be approved yet by the FDA. We do have time for just a couple of questions. I want to be conscious about everyone's time.